Good afternoon, good morning, good evening, colleagues and friends all over the world, wherever you are. Thank you so much for joining us today for this webinar on respiratory disease in the era of COVID, a global perspective. I'm Heather Zah, I'm president of the Forum of International Respiratory Societies, and together with my co-chair, Dr. Sarah Rylance from World Health Organization, we're delighted to bring you this webinar. We've got a very interesting, diverse webinar planned, and of course, a really important event to mark World Lung Health Day on the 25th of September. So we'll have two presentations, the first on global burden of disease, the second on strategies for prevention and treatment, followed by presentations from each of the FIRS members, societies, and at the end, we hope to have a lively question and answer discussion. If we can ask you, please, to put questions in the chat as you go along, that will be fantastic. And I think we should just go straight into the first presentation then. It's a great pleasure to ask Dr. Mark Cohen, past president of ALAT and immediate past president of FIRS and currently in private practice in Guatemala City, to give us the first presentation. Mark, the global burden and risk factors for the 5 big respiratory diseases and the impact of COVID. Thank you.
Thank you so much, Heather. I'm glad to see you here in Guatemala, nice and early, and celebrating the World Lung Day is definitely important for us on the 25th of September. I'm just going to be pulling up my screen, or trying to again. We had done this already before, and we'll see. Can you see my screen? Yes?
No.
Mm-hmm. Okay, we'll do this again. And okay, can you see it now?
Perfect.
Okay. Well, once again, we're celebrating World Lung Day, and we're going to be talking about the respiratory diseases in the era of COVID, and I'll be talking about global perspective. One of the most important things is we know that lung health is vital throughout the lifespan. Both acute and chronic respiratory diseases are a clear threat to life, health, and a productive and human activity. And we have really seen this during our COVID-19 pandemic. We know that the respiratory diseases are associated with a high morbidity as well as a higher risk of mortality, and it increases direct and indirect costs. Due to the persistent symptoms that the patients have, it limits their activities, and due to intermittent exacerbations, they require acute care. They affect people in all the world, but disproportionately, unfortunately, in low and middle income countries, due to lack of resources to manage and prevent disease, as well as less research. So it's imperative that the resources devoted to acute and chronic respiratory disease become a top priority in the global decision making in the health sector. The Forum of International Respiratory Society Diseases has brought up the global impact of respiratory diseases, and we have called the Big Five, which are the 5 most important in numbers as well as in mortality, and they can come from acute, as we include acute lower tract respiratory infections, as well as tuberculosis, and then the chronic lung diseases that we'll be talking about: COPD, asthma, and lung cancer. Why are these important? We know that the WHO has shown that the leading causes of mortality, chronic obstructive pulmonary diseases, and then the number 3 leading causes globally. 4th is lower respiratory infections, and 6th is lung cancer. When we look at the low and middle income countries, we see that COPD and lower respiratory infections are 4th and 5th, and tuberculosis are in number 7. This is important because we need to know what's the problem so that we can improve the healthcare of our patients. We know that pneumonia, especially in children, thank God, has decreased from over 2 million in 1990 down to probably 1.5 million or 2 million in 2019. This has been improvements in childhood wasting, air pollution, poor sanitation, and less poverty, despite there's still a lot to work with. And then also with the new technologies, with newer vaccines and antibiotics, we have seen that decline. But then we see in those over 70, there was definitely a big number, and we're still in a kind of a plateau in those above 50 years old. We know that there's unfortunately a disparity of the mortality, especially in low and middle income countries in Africa and part of America, as well as Southeast Asia. And we know that we need to work on that. And working on that is reducing the risk factors. And we know that these risk factors overlap with other interventions that causes other diseases. So definitely that would benefit multiple diseases. What are the risk factors in children? Child wasting, indoor and outdoor pollution, low birth weight, and definitely short gestation, child underweight, and non-exclusive breastfeeding. So we need to stimulate these risk factors and work on prevention. In adults, usually it's going to be more outdoor pollution as well as smoking, and then secondhand smoking being important. We know, as we have learned from the pandemic, that with the molecular microbiologic panels, viral etiologies have become a major burden, not only COVID, other viruses. And we know that these aren't going to be treated with antibiotics. So if we make a better diagnosis, we're going to use less antibiotics and hopefully less resistance and Clostridium difficile gastroenteritis, as well as hoping for new vaccines and new antivirals. The pandemic, it's been almost 3 years now, and we look at September 21st, we see that 610 billion confirmed cases with 6.5 billion deaths, unfortunately, in the world. But we also see that we've been working hard with vaccination, with more than 12 billion vaccines worldwide. But unfortunately, this has been disproportionate, as you see, especially in Africa and areas of Asia, as well as Latin America. And the global burden of viral infections has really been different during the pandemic. We see that 2020, 21, we didn't see any influenza, we didn't see any RSV, but when we do look at the numbers afterwards, we're seeing that we still see a lot of SARS-CoV-2, but we also see that RSV is giving us new input, and we need to be looking at, and hopefully in the future, we'll have therapies and also vaccines to prevent these infections. The other thing is we're seeing that there's a difference in seasonality of influenza and RSV that we were used to. So I think we need to be conscious that they can happen at any time. We see that the invasive diseases, especially pneumonia in kids, like I said, has really gone down. And looking at the estimated deaths in the world, we know that Africa and Asia are the ones that have the higher morbidity and mortality. The second acute infection is tuberculosis. We have acute, and then we have the chronic presentation of post-tuberculosis lung disease. And we know that TB will kill 1.5 million deaths, at least in 2020. And it's the second most lethal infectious disease next to the COVID-19. We know that 10 million people develop TB annually, and of those, 1 million occur in children. This is a disease that needs to be diagnosed early and can be treated, but unfortunately, 2 to 4-fold odds of having persistent changes as in this spirometry and with changes as shown in bronchiectasis in people that have been treated for tuberculosis. There's a higher risk of symptoms and recurrent infections or exacerbations, and the mortality is probably 3 times greater than those that don't suffer from tuberculosis. And then talking about the chronic respiratory diseases, we see that as we get older, we're going to have more and more of the chronic respiratory diseases. And the number one disease there as we get older is COPD. Asthma, definitely in males and females, is also important. And we see interstitial lung disease, especially in males for idiopathic pulmonary fibrosis, but then for females, also with connective tissue diseases that will give fibrosis. These are important contributors to the burden, and we know that there's more than 545 million individuals in the world with chronic respiratory diseases, and they definitely have a high burden, increased deaths, and definitely disabilities. We see that COPD carries the higher burden with 380 million, which is around 11% average of the population have COPD, and of those, 3.2 die each year. Asthma, also a high burden, and we see that the majority of deaths are in low and middle income countries. We see once again the disparity of asthma and COPD. Africa, America, as well as some areas in Asia, especially COPD, we see that we have a higher incidence of COPD, probably because of no control of the risk factors. There is a higher mortality in males and females, especially in Southeast Asia, where there is definitely a high mortality in COPD. And then we see that in females and males. And then the years lost in life, once again, COPD is the predominant disease, but asthma is a high contributor. And then pulmonary fibrosis is definitely one of the higher years life lost. And then in disability, asthma and COPD are the top two. So we really need to work on prevention. And then the third chronic respiratory diseases of our big five is lung cancer in both sexes. Definitely lung cancer has become the second most prevalent cancer in the world, with more than 2.2 million new cases, but is the number one cancer mortality, either above breast and colon and stomach cancer. We see the distribution worldwide in males. We see the blue over here is for lung cancer. We see the higher income countries are definitely having higher incidence of lung cancer, versus breast cancer is the number one incidence in females, but in the high income countries, except probably China, we see that there's a high incidence of lung cancer in females. So looking at how we can work on preventing this chronic respiratory diseases, we need to look at the risk factors. And a lot of these is, as you see in the purple boxes here, smoking is the number one preventive killer over here. Secondhand smoking, but then outdoor and indoor pollution air is something that we need to work very hard in preventing, and WHO has given us the numbers of prevention for the outdoor pollution. How have we been doing? Have we been working? And we see that a lot of the chronic respiratory diseases from 1990 to 2017, we've been able to reduce the mortality and disability, except for pneumoconiosis. All the other diseases have really gone down, but pulmonary fibrosis, we see an increase in the mortality of these patients. So we need to work harder on the interstitial lung disease preventive things. And as we look back, we're really looking into what we call the genomics. Genomics is gene plus environment plus time in the lifespan. And we know that intrauterus, we have changes in our genes that will definitely show in endotypes and biomarkers as we develop and as we are born. And then as we go on, those initial incidents of problems at the gene and environment exposure will give us very healthy kids or not too healthy kids. And every hit that they have, either infections or exposure, will definitely change the endotype in these patients. And this is going to be a additive or summatory effects on the lifespan that will turn into having every disease. For us, the chronic respiratory diseases, especially COPD and asthma and interstitial lung disease, are definitely important when we look at the lifespan of the gene and environment exposures. This is my presentation of the global burden of the chronic and acute respiratory diseases, and I thank you, and I hope that you will have a wonderful World Lung Day on the 25th of September, and I will pass on to Sarah Rylance, who will present our next speaker. Thank you very much.
Thank you so much, Mark. That was a really excellent start to our webinar, and you covered a huge breadth of information there, covering right across the spectrum of different respiratory diseases. So congratulations in managing to cover such a broad scope in a limited time. I'm now going to introduce Professor Guy Marks. Guy is a respiratory and public health physician and an epidemiologist. He's based in Sydney, Australia. I'm sure he's known to many of you. He's the president of the International Union Against Tuberculosis and Lung Disease, and he's going to give us a talk today focusing on the major opportunities for gains in global lung health, looking at a few well-targeted interventions. So Guy, over to you, please. Thank you so much.
Thank you very much, Sarah, for that kind introduction, and thank you for inviting me to participate in this important event. Thank you also to Mark for his excellent coverage of the burden of the 5 main respiratory diseases, and also of the relationship between risk factors and disease. In this talk, I'm going to take a slightly different approach and focus on the risk factors and the treatments themselves, the small number of things that I believe that we can do that would make a large difference to global lung health. I think there are some big opportunities for health gain in general, and specifically in this context for lung health gain. And I'm going to focus for a significant part of this talk on the concept of safe air. We've known for 150 years, we've talked about safe water and the need for ensuring that we have engineering and cities designed and residences designed so that people can have safe water to drink. We have not paid so much attention to safe air. And if we've learned anything from the COVID pandemic, hopefully we have learned that safe air is important. But it's not only important about infections, it's important for a number of other reasons. And here I'm going to focus on tobacco and smoking, on air pollution, on workplace exposures, and on airborne transmission of infections. In addition to safe air, I think there's a major opportunity for gain in ending tuberculosis. We heard from Mark that tuberculosis is the biggest infectious disease killer in the world before COVID, other than COVID. 1.5 million deaths a year, and there are ways which we can now end TB. And finally, treatment is important, and particularly for some diseases that we can't prevent. And asthma is one of those. We don't really know how to prevent asthma, but we do know effectively how to stop people from dying of it and from having severe attacks. And I'm going to talk about that as well. So let's talk about safe air. We need to end tobacco. We've been trying to do it for a long time. Nearly 20 years ago, the Framework Convention on Tobacco Control was adopted by the World Health Assembly, the first such framework convention that they have adopted for any threat to health. It was a major advance and has led to major advances in the battle against tobacco. Key elements of the Framework Convention and of the work that's being done underneath it include the need to ban advertising and promotion of tobacco products, and the flip side of that, to make sure that we have graphic warnings and plain packaging, two things that have been shown to be highly effective in reducing the uptake of smoking. We need to restrict smoking in public places and in workplaces, and as many places as possible, actually. And that has also been shown to be very effective. There are fiscal tools that are available to us, mainly taxation, that help us to raise the cost of smoking, and that also is effective in reducing. All of this requires regulation, but not only regulation, it requires enforcement. And it's the last element which has been proven to be one of the major Achilles heels in our strategy to end tobacco and smoking. One of the reasons why regulation and enforcement has been so difficult has been the pernicious influence of big tobacco companies on public policy around the world. This is this is a problem in high-income countries where they're influencing government and trade policy in ways that limit our ability to implement public health measures. But it's also a major problem in low and middle income countries where they can have a great deal more influence and where they're trying to find their way into new markets. Recently, we've had a lot of debate and discussion around harm reduction and e-cigarettes or heated tobacco products. We need to avoid this distraction of harm reduction in relation to tobacco control. It is a Trojan horse for big tobacco companies to divide and conquer and to damage the public health efforts that have been taking place over the last 20 years. So tobacco and smoking is one aspect of safe air, but in our outdoor environment, we have many other sources of unsafe air. And basically, they can be divided into those that come from fossil fuel combustion, mainly transport and energy sectors, but also in other industries, particularly smelting and so on. And apart from fossil fuel combustion, there is then burning of vegetation and other biomass, things that haven't yet become fossil fuel, but are still growing fuel, if you like. And there are many areas of life in which combustion of vegetation and biomass is important. In agriculture, it's used as a part of the agricultural process of getting rid of rice stubble, for example, getting rid of pests and others. It's used in households, both for cooking and heating. And it's used as a tool for land clearing, another aspect of farming, or for other purposes. And finally, it's also, of course, occurs naturally due to forest fires becoming much more common in the era of climate change, and for fire control, for preventing future fires. So all of these are ways in which we are contributing to air pollution in our atmosphere, both outdoors and indoors. There are solutions, and many of them are available to us now. We need newer, and we have newer, cleaner processes for generating energy, for powering transport, for managing agriculture, for providing cooking and heating, and for fire control. But we need the political commitment to see these newer, cleaner processes implemented. And much like I mentioned before, there are many entrenched interests, business interests, which tend to work against the introduction of these cleaner processes. And a part of the campaign to improve public health in this aspect involves combating those entrenched interests. Fortunately, in this case, there is a major synergy, at least in relation to energy and transport and fossil fuel reduction, in the need for carbon pollution reduction to combat global warming. And that synergy, those co-benefits, are things that we can realize or leverage off to improve the quality of the air that we breathe. I want to talk about another aspect, a localized aspect of safe air, which is the workplace. Much ill health across the world, and particularly now in low and middle income countries. In the past, it was in the global north. Now this is to some extent being controlled in wealthy countries, but now it is a problem in low and middle income countries. Workplace hazards such as asbestos, other dusts, and sensitizing agents and irritants, which cause asthma or asthma-like syndromes in people. These are the major hazards which are associated with poor lung health amongst workers. And the solutions to these have been known for a very long time. Essentially, we need to replace hazardous substances in the workplace, removal of asbestos, alternative agents so that we're not exposing workers to sensitizing agents and dusts. Where this is not possible, we need to implement engineering controls. And finally, in this hierarchy of controls, probably the least effective for this purpose, personal protective equipment, respirators and masks. I want to now turn to ending tuberculosis. Personally, this has been the area in which I've been most active recently, and one that's motivated me a great deal, the need to end tuberculosis as a global health problem. And in order to do this, we need to come to terms with the nature of tuberculosis epidemiology in high burden settings. It's different in high burden settings to what we see now in countries where tuberculosis has already been largely eliminated, in Northern Europe, in North America, and in Australia and New Zealand, and in some parts of East Asia. But in high burden settings, much of the rest of the world, most people get TB, most people who are getting TB are people who've been exposed and infected recently. People get TB because they're infected by other people with TB. And this is what we need to understand about the nature of TB in high burden settings, that if you can stop people being infected, you will stop people getting TB. Seems obvious, but in fact, in many cases, we seem to have lost sight of this very simple statement. We did a study in Vietnam in the last few years about community-wide screening for tuberculosis in southern Vietnam. And in this study, we took a number of communities, villages really, 60 villages, in which we screened the whole population in those villages for TB. We assumed that anybody in those villages could have TB, and the only way that we could find out those who did have TB was to test everybody, and that's what we did. And we did it for 4 years, and over 4 years, we saw what we expected. When we found and removed infectious cases from the population by treating them, we reduced the prevalence of TB year on year by 72%. And where we compared this with another group that had not been screened, the reduction was 44%, nearly half. So it is possible to substantially reduce the risk that people will get TB by finding and treating those people who have TB so that they do not infect other people and those people do not go on to get TB. It's basically breaking the chain of transmission. So to end TB in high burden settings, we need to screen everyone for TB in those high burden settings using one of these tests that's available. We need to make sure that everybody who we find who has TB is effectively treated. And then we need to repeat it. And we need to keep repeating it until we find very few cases. And we have lots of evidence from countries where TB has essentially been eliminated to show that this works. So this is Australia during the 1950s and 60s and early 1970s, when a campaign of widespread community screening for TB led to a rapid decline in TB, so much so that by the mid-1970s, there were no more cases to find, and we could stop repeating. We could stop the campaign. So this is what I believe we need to do in places with a high burden of TB. Finally, I want to talk about asthma. And what we need to aim to do with asthma is to stop people having attacks. Now, unlike all of the other diseases we've talked about, where we can stop people getting the illness, we don't yet know how to stop people from having asthma. But we do, as I said earlier, know how to stop them getting attacks. What we need is effective, safe, and accessible treatment for people with asthma. And essentially, this is centered on a drug that's been available to us for 50 years, inhaled corticosteroids. We've known for many, many years that people who use inhaled corticosteroids for asthma are much less likely to die of their disease than those that don't. There are now various regimens in which this drug can be used, And there's recent evidence from studies done mainly in high-income countries, but with some evidence from lower-income countries, that a regimen based on a combination of a reliever with an anti-inflammatory inhaled corticosteroid that is used as required, PRN, if you like, used as required, seems very promising as a way of providing this effective, safe, and accessible treatment for asthma. There are unfortunately many barriers to getting this drug into people, particularly in low and middle income countries. Many doctors who are responsible for caring for patients with asthma don't know about it. The drugs are often not available because of difficulties in getting regulatory approval. There are difficult distribution networks. They can be quite expensive. The price is too high. They are delivered by inhaled devices, and these are not simple to make. They need to be well made and deliver the device properly. And often they're not always easy for patients to use, and then patients need to be educated about how to use them. So these are some of the barriers, but there are strategies in place to try and overcome these barriers and make this effective, safe, and accessible treatment for asthma available to everyone who has the disease in low and middle income countries. So just to end, I believe that to improve lung health, we need to focus on a few key drivers of lung ill health. We need to make sure that we need to focus on unsafe air and make sure we have safe air in homes, in workplaces, and in public places. We need to end endemic transmission of common infectious diseases such as COVID and tuberculosis. And we need to overcome the current lack of access to effective medicines, particularly for asthma and for other respiratory diseases. We need to focus efforts to overcome those barriers. And I thank you for your attention. I'll just show one more slide, actually, which is this one, which is to an advertisement for the World Conference on Lung Health, the Unions Conference, which is coming up in November, where many of these sort of issues will be discussed. And so you'd be very welcome to join us at that conference. So thank you very much.
Thank you so much, Guy, for a wonderful presentation and the focus on the three key areas that are drivers of the huge burden that we've heard about, with some really effective and available important interventions that you've highlighted, that could be scaled up in areas where they're not. So hopefully we get a chance to discuss more of that. But I think this leads very well onto the next part of our webinar, which is representatives of each of the FIRS societies talking about impactful programs in their regions that could be scalable. And so it's a real pleasure to ask our first speaker, Professor Stephanie Levine from the American College of Chest Physicians, to speak to us on the first 5 minutes and time to diagnosis project. Thank you, Stephanie.
Thank you, Dr. Czar and Dr. Rylance. The mission of the American College of Chest Physicians, or CHEST, is to champion the prevention, diagnosis, and treatment of chest diseases through education, communication, and research. In celebration of World Lung Day, I would like to share with you a few recent CHEST initiatives aiming to improve lung health and patient care. Next slide, please. The first is called Bridging Specialties, Timely Diagnosis for ILD Patients. Together with Three Lakes Foundation, CHEST launched an initiative in January of 2022 with the aim to reduce the time it takes to diagnose patients with interstitial lung diseases by bringing together pulmonary experts and primary care experts. Data from the Global Burden of Disease study places ILDs among the top 50 causes of global years of life lost, and these numbers are on the rise, as you heard from Dr. Cohen's presentation. With over 200 types of ILDs and the difficulty of diagnosing these diseases, a global assessment is hard to achieve, but the best United States-based estimates are 400,000 people living with ILD. Because of the rarity, ILD symptoms such as shortness of breath and cough are often initially attributed to the more common COPD or asthma. The average ILD patient will wait over 2 years for an accurate diagnosis. During that time, the disease will progress, and once the lung develops fibrosis, it is thought to be permanent. Through this initiative, a steering committee composed of experts from pulmonary and primary care assessed the current state of practice to identify barriers and opportunities. The results are recently published in a white paper, and the group is now working together to create resources for clinicians to enable more accurate identification of ILDs like pulmonary fibrosis. You can learn more about the initiative and sign up for updates by scanning the QR code on this slide. Next slide, please. Next, I'd like to share the First 5 Minutes initiative. Extending beyond the boundaries of lung health, but critical to impacting it, the First 5 Minutes initiative aims to enrich the patient-clinician experience and care through teaching enhanced, empathetic listening skills. In the fall of 2020, CHEST hosted a platform for patients to share their healthcare experiences across 5 regions in the United States. We called it the Listening Tour, and what we heard from the participants signaled glaring disparities related to access to healthcare, sometimes caused by non-healthcare related issues such as language barriers, transportation issues, and job insecurity. Participants also signaled that often a lack of trust between a patient and their clinician prevents them from raising these barriers to care with their provider directly. As an association of clinicians, CHEST is well positioned to help make a positive change as it relates to trust between a patient and their clinician. Through a partnership with the Academy of Communication in Healthcare, the First 5 Minutes reinforces strategies around empathetic listening for clinicians. The pilot program of the course took place in San Antonio, Texas, where I am based, and as a participant, it was truly moving. We are eagerly translating the in-person experience into online modules and will be disseminating the content in partnership with Humana, which is a large healthcare company and insurer in the United States, to reach a broader audience of providers. I would encourage all practicing clinicians to take the course and ask that my first colleagues help us spread the word when the modules are ready. Learn more by scanning the QR code shown on this slide. Thank you for your attention.
Thank you so much, Stephanie. It's great, and it's a shame that you have such a brief amount of time to talk to us, but really interesting to hear about the projects and highlighting the importance of timely diagnosis of lung disease and absolutely key areas of trust and communication. So thank you. Our next speaker is Dr. Shannon Carson from the American Thoracic Society, and he's going to be talking to us about the MECOR program. So Shannon, over to you. Thank you.
Hello, and thank you for inviting me to speak briefly about the MECOR program. I cannot see my slides up, but I'll trust that others can. The ATS MECOR program is MECOR stands for Methods in Epidemiologic, Clinical, and Operations Research. It is a progressive training program for clinicians, investigators, and academicians and public health professionals who primarily work with pulmonary diseases, primarily the big 5 that you have heard about this morning. The objective of the MECOR program is to build research capacity in low and middle income countries, primarily through research training and mentorship. The program is a series of 3 or 4 courses that students from low and middle income countries attend that are taught by faculty sponsored by the ATS and importantly by local and regional thoracic societies to form their intensive 1-week training programs, as I said, a series of 3 of them, and opportunities to build mentorship relationships between the faculty and students that last during the 3-year course of the program and beyond. The goal is for graduates to learn how to conduct clinical research within their environments, focusing on research questions that are important to their environments, and to eventually publish those research studies as much as they're able. In addition, the MECOR program is focused on leadership development through the faculty-student mentoring relationships and through networking with each other and through inspiration from immersing themselves in academic questions and academic programs. Our goal is to help students advance within their academic careers, or importantly, to advance within their local and regional healthcare infrastructures so that they can influence healthcare in their areas in ways that are guided by what they're learning about reading literature, understanding literature, and contributing literature and advancing healthcare. And then finally, the program focuses on research and clinical networking by forming a community across the globe of young investigators interested in international health and international health problems. Our goal is to help them continue to inspire each other to share common cause and advise and mentor each other as they progress in their careers. The MECOR program has trained over 2,000 graduates from 7 training sites. The program started about 25 years ago. Importantly, a number of our graduates who were former students have become faculty themselves, and helping the program to become self-sustaining across their regions and the country. So last slide, please, if they're up. As you can see from this last slide, the program has focused primarily on the Southern Hemisphere, with the program starting in Latin America 25 years ago, our largest and one of the more successful courses, then moved to Africa with partnership. So the partnership in Latin America is with the Latin American Thoracic Society, or ALAT. Partnership in Africa is with the Pan-African Thoracic Society, who's been a valuable sponsor over the years. The course then moved and includes Turkey with the Turkish Thoracic Society, India, Vietnam, Indonesia, and then the last course to get started was China, with a focus on health problems in Central and West China. The Indonesia and Vietnam courses are on hold as we cycled through a lot of the students who were available who could speak English, and discussions are going on to combine courses or students from Vietnam, Indonesia, perhaps Cambodia, Thailand, other countries in Southeast Asia for a regional course that functions similar to Latin America and Africa. So these courses continue today. We had to pivot to online formats during the COVID pandemic, which were less ideal than the person-to-person interaction, but were still rather successful. And we were proud that we were able to not have young investigators left behind simply because they cycled around to be able to attend only during a pandemic. So we also learned quite a lot from each other about pandemic responses. So the studies that they conduct are important to the problems that you've heard about today. I can think of a paper that came out of the China course last year, focusing on a large cohort of miners in central China exposed to silica and the prevalence of COPD and silicosis or pulmonary fibrosis in those patients. It was a unique opportunity to study such a problem. Or cost effectiveness analysis of asthma drugs in Nigeria to help a local area justify increased contributions or resources to that problem in that area. As examples of what the specific research studies can do to help understand and address these diseases we've heard about today. Thank you.
Thank you so much, Shannon, for speaking to that. The MECOR program has been an absolutely extraordinary program and has built much capacity, much needed capacity globally. Certainly speaking for Africa, it's been amazing. So thank you. We now move on to the next presentation by Professor David Lam from the Asian Pacific Society of Respirology. And he's going to talk to an important topic in terms of lung screening, an opportunity for early detection of lung cancer. Thank you. And just a reminder, please, to put any questions in the chat as we go along.
Thank you, Heather. And now thank you for the introduction, and I'm glad to share today with colleagues that switching to one of the other big five here is lung cancer, because we are now seeing an opportunity for early detection of lung cancer through lung screening. Next slide, please. As you can see and have heard from Dr. Cohen before, that lung cancer still top the list of cancer mortality among the world, no matter is for men or for women. Next slide, please. And of course, we all know that the prevalence of lung cancer actually ties in quite similarly to that of the prevalence of smoking. Next slide, please. But we are all aware that other than smoking, there could be other risk factors as well. And why do we want to try to detect lung cancer early? Is that we all know that most of the time, cancer patients, especially lung cancer patients, present late and present in the advanced stage. And with the presentation at advanced stage, the chance of cure with treatment is of course lower. The chance of curative treatment, having curative treatment of it, is actually lower as we get along to advanced stages. Next, please. And we all know that especially in this part of the world in Asia, we are facing a prominence of patients who are female non-smokers. Of course, they are not taking over male smokers, but still we are facing a lot of them increasingly prominence among patients with lung cancer. So that's why we would like to see if we can undertake new technology in order to try to detect them early, in order to achieve early detection and complete cure of the disease. Next, please. And alongside with our screening, it's inevitable that we will be getting the detection of other abnormalities on imaging, like lung nodules of various different sizes, shapes, and composition and numbers. And a lot of times, this is coincident with the previous epidemic of tuberculosis, that we see a lot of granulomas, but at the same time, they overlap with appearance with some that may be incumbent development of lung cancer into a malignant nodules. Next slide, please. So that's why we're trying to see if we can try to detect lung cancer at the same time when we picked up incidental lung nodules. These has all been shown to be able to contribute to diagnosis or detection of lung cancer in the early stage. And next, please. And we have all the now international guidelines suggesting how we manage these incidental pulmonary nodules. Next, please. So that's why we will try to see if these through lung screening and lung nodule management program, we can try to drive a stage shift towards early stage at detection and diagnosis to improve the cure of lung cancer in the world, especially in this part of the world in Asia. Next, please. So just like to summarize here is that we'll promote early detection and screening and try to enhance the detection of lung cancer in the earliest stage if possible. And through the lung cancer screening program and the lung nodule program that can be run concurrently, that we are hoping to have a stage shift towards early stage of lung cancer diagnosis. And these lung nodule program and lung cancer screening program, of course, cannot run alone, but needs the accompaniment of smoking cessation. And with these, we look also forward to the potential development of further biomarkers or even artificial intelligence to help in the early diagnosis, screening, and early detection of lung cancer. Next, please. So I hope today I've shared with you one of the big how we foresee how to tackle one of the big 5 respiratory diseases, that's lung cancer, and I hope you all enjoy our coming celebration of the World Lung Day on the 25th of September 2022. Thank you very much.
Thank you so much, David, for your talk and for again covering a huge amount in a short space of time. And I think really what you were talking about really reflects as well what Stephanie started talking about, reflecting the importance of early diagnosis of lung conditions, be they interstitial lung disease or tuberculosis or lung cancer. So I can see the overlap between the different presentations here already in terms of looking at synergies and opportunities for sharing knowledge and impact across the different diseases and the different societies. So moving on now, we have Dr. Carlos Rebelo Cordero from the European Respiratory Society. Apologies if I've said your name wrong. And we're going to hear about living guidelines for COVID-19. So Carlos, over to you, please. Thank you very much.
Thank you, Sarah and Dieter. Thank you for the nice introduction. And I'm a pulmonologist from Portugal at this moment, president of the European Respiratory Society. And as part of the RS mission, so to promote lung health under our 3 main pillars of science, education, and advocacy, we are happy to participate in this World Lung Day 2022. Can I have the next slide, please? As an impactful program to combat respiratory diseases during recent pandemia, I would like to underline the first ERS living guidelines that were delivered by ERS experts in the field. This was the first publication. This first publication was last year in April 21. Can I have the next one, please? When there was high mortality rate due to COVID. Next, please. Next. Oh, sorry. Yes, there is an before that one, the previous one, because there was an animation, but no problem. We had at that moment, a high mortality rate. Of course, this standardization and this standardized management approach could improve quality of care and promote the reduction of mortality due to COVID. Of course, as these guidelines are called living guidelines, those will be regularly or are being regularly updated, as it is now in the next slide, please. Now you can move for the next. Yes, again. Okay, so this is an example of this approach, well, with conditional or strong recommendations for interventions, as you can see here, not only in supportive care, but also coming from moderate diseases that do not require oxygen therapy, or more severe requiring oxygen, or even critical diseases needing ventilatory support. So those were made on the basis of conditional or strong recommendations. Next, please. Under the same methodology, the new guideline was published last March this year in order to update the evidence on COVID management. And the next, please. And in this table, if you can see, you can see the previous conditional recommendations moving now to strong recommendations, either in favor or against intervention. This is the case, for instance, of IL-6 receptor antagonist. Now it's strong recommendation for the intervention, or the azithromycin and the hydroxychloroquine. Now it's strong recommendation against intervention. And also some new recommendations from last year are now moved for strong recommendations, in some against, like it is the convalescence plasma. And this is an example of what is really the living guideline with what happened with the evolution of the pandemic. Next, please. So actually, as the pandemic is less problematic, new updates, of course, will be released when and if needed. And of course, the task force remains prepared to initiate the next update if needed. Next, please. And so I'd like to thank you for your attention. And again, ERS is very happy to promote lung health for all under the scope of FIRS, and to promote this World Lung Day on the 25th September 2022. Thank you for your attention.
Thank you so much, Carlos. And I mean, I think these have been really important guidelines for guiding people around the world in how to treat COVID, especially as there's so much publications and data coming out, and the fact that they've been produced so rapidly and revised so quickly, I think have really impacted on clinical care and probably saved a lot of lives. So thank you so much for presenting that, and to ERS for leading that. We go on to our second last presentation by Professor David Halpin from the Global Initiative for Chronic Obstructive Lung Disease, GOLD, and he's going to speak on addressing the global burden of COPD, the GOLD report, and low middle income countries. David, thank you.
Thank you very much, Heather. So GOLD has just passed its 20th anniversary, and for a lot of that time has concentrated on producing the annual reports, which have contained recommendations about the management of COPD. But over the last few years, we've taken a broader approach and taken on more of the advocacy that was part of GOLD's remit when it was established. And we've been working particularly on raising awareness of COPD. Mark has already talked about the burden of COPD, the fact that it is currently the third commonest cause of death worldwide. And we're very aware that much of the burden currently and undoubtedly in the future will lie in low and middle income countries. And that's due to a combination of things, increasing life expectancy, so people in these countries will live long enough to develop COPD, increasing smoking rates as a result of the efforts of tobacco companies, as Guy talked about, and also the other diseases which are more treatable becoming less prominent in these countries, so infectious diseases. And so over the last few years, we've tried very hard in GOLD to raise awareness of COPD and the burden in low and middle income countries. We held a summit a few years ago and published the outputs of that. And in support of World Lung Day, to try and raise awareness, we've published two papers, one in the Blue Journal, one in the Lancet Respiratory Medicine, which will be coming out on Saturday, to try and focus the burden on COPD alongside the other 5 important lung diseases that we've talked about in this webinar. So GOLD has extended its remit a little bit and has begun to contribute to the literature. We've been particularly interested in pre-COPD and early COPD, and recognize, as again, Mark talked about, this concept of getomics promoted by Alvar, the current chair of GOLD, where we're thinking about the interaction of genetics, about the environment, and about time, and recognizing that much COPD in lower middle income countries is due to early childhood events and perhaps young adult events, rather than necessarily being related to smoking. And we recognize the need for a lot more research into this, and particularly in the optimal management of these other causes of COPD. And so that's been an active strand of work that GOLD has been pursuing. GOLD is also currently a very active member of GUARD, which Sarah leads at the moment. And we're very strongly supportive of the concept of improving access to inhalers. Guy talked about the importance of inhaled steroids and the power to change the management of people with asthma worldwide. Although we can't control COPD in the same way that inhaled steroids can control asthma, effective therapies can make a huge difference to patients' abilities to do things, to their quality of life, to reduce the rates of exacerbations. So ensuring that patients worldwide have access to effective medicines for COPD, and that includes other things like pulmonary rehab as well. It's not just drugs that are important. That's become an important thrust of GOLD's work in recent years. And just finally, I want to say that we're very keen to help countries adopt and adapt the GOLD recommendations for local needs. The GOLD report is designed as a framework to describe what is best practice using the best treatments that are available worldwide. We recognize that not all countries are able to afford all of those, and we would be keen to work with local countries to help adapt the GOLD report for their local needs. And finally, to really make a difference, I think it's important that GOLD supports the sharing of good practice. We have the World COPD Day as distinct from World Lung Day. And on World COPD Day, we share experiences and practices from different countries around the world, particularly LMIC, about raising awareness of COPD, reducing the stigma of chronic respiratory disease, and trying to improve access to diagnostic techniques. So I just wanted really to give you that brief overview of GOLD and explain how we are expanding our remit beyond just producing the GOLD report into advocacy, and with a particular focus on the burden in low and middle income countries. Thank you.
Thank you so much, David, for that brief overview, and really demonstrating to us that GOLD has a commitment to improve the situation for people living with COPD in low middle income countries, and particularly around the issue of access to treatment, be it inhaled medications or, as you mentioned, other therapies such as pulmonary rehabilitation. So thank you for that. And we move on now to our last presenter. Rafilo Masekela is now going to talk to us from the Pan-African Thoracic Society, and she's going to talk about African initiatives during the SARS-CoV pandemic. Just before Rafilo starts speaking, if I can just encourage people to pop any questions they may have for our presenters into the chat. When Rafilo has finished, we'll have some time to open up for a general discussion. So please feel free to put questions into the chat, and we'll try and allow for some discussion when Rafilo has finished. Rafilo, thank you so much. Over to you, please.
Thank you very much, Sarah. So I'm going to be talking about African initiatives from a Pan-African Thoracic Society perspective. So during the pandemic, I think all of us experienced this across the world, but I think more so in Africa, where I think the kind of initiatives that had to be done during the pandemic may be slightly different, as we had many challenges to address during this time. Next slide, please. So I'm just going to touch on a few initiatives. These are across the continent. We had some clinical activities, research outputs, and one area that I think was quite important was access to oxygen and delivery of oxygen for most patients. And we also had some publications as well as webinars, and I will conclude. Next slide, please. So I'll start with Nigeria. I think one of the exemplars in terms of what they did in Nigeria during the pandemic is they started a mobile sort of prescription refill tool with patients in their pulmonology clinics. They also pivoted to doing telephonic consults. And I think one of the other areas that was a focus in terms of the clinical practice was actually accessing diagnostic to their patients. In this one group in Lagos, they actually developed guidelines on how to conduct spirometry safely. This photo was not during the pandemic, but they had gone through training prior to the pandemic, and they used that to give safe spirometry to patients during the pandemic. And as you can see, 2/3 of people that were referred at that time actually had abnormalities and required management. Next slide, please. Now, I'm just going to share some work around COVID research work that was conducted in Uganda from Bruce Kirenga's group in Makerere. They were involved in a number of research projects, both in terms of diagnostics as well as treatments. And one was also using natural products that are found in that country in Uganda. Next slide, please. Next slide. They were also involved with a number of drug trials, clinical trials, some phase 2 as well as phase 3 studies during the pandemic. Next slide, please. And of course, I think with Africa, we had huge challenges with regards to access to vaccines across the continent. And in Uganda, they were also involved in testing various different types of vaccines. And also what was also addressed by this, the Lung Institute in Makerere was also around access to vaccines for both healthcare workers as well as patients, as the communities. Next slide, please. As I did mention, I think one of our biggest challenges across the continent was access to oxygen. And oxygen availability is very limited, particularly at the primary care level in district as well as regional hospitals. And even in some facilities in tertiary centers, there's very limited oxygen supply. So the Kenyan Respiratory Society was very involved with procurement of oxygen concentrators as well as procuring oxygen for the more primary care level hospitals. And you'll see on the right side, this is actually a picture from the Malawi Liverpool Wellcome Research Program in Blantyre. This hospital prior to the pandemic didn't have a oxygen supply which was consistent for the whole hospital, and they managed to get a whole oxygen plant funded during the pandemic to improve access to oxygen across the hospital. So that was also another initiative by this MLW under the leadership of Stephen Gordon. Next slide, please. We also, as PATS, also have had a number of publications in our journal, the Pan-African Thoracic Society, around COVID and challenges with COVID. As you may know, we not only had a very different dynamics in terms of the patients that we're looking after. Diseases like HIV, tuberculosis were not really a focus in many high-income countries. So we had to also find a way to conduct research in this area, as well as we had a number of webinars, so bi-monthly webinars, to share experiences in managing patients in a pandemic in very low resource settings, and areas of good practice that could be disseminated across the continent. Next slide, please. So we had a number of initiatives, and I think a lot of PATS members took a leadership role during the pandemic, as I think was the same across the world. For us, issues of access to oxygen conducting research in a context where there's limited resources, and really advocating for vaccines, for children as well as adults, and really creating new platforms for accessing our patients, especially in the more rural communities, with some of the initiatives that were done in the COVID pandemic era. And I'd like to conclude by wishing everybody a World Lung Health Day on the 25th of September. Thank you.
Thank you so much, Rafilwe, for that excellent tour de force on a response to COVID in Africa and some very impressive initiatives. And if I can ask now all the speakers to please put on their videos, and we are going to take some of the questions. There are quite a few in the chat. Please ask our speakers to answer some of these. So I'm going to start. I've tried to join the various questions together. There have been a number of questions around COVID. And the first one, and maybe I'll just list them, and then for efficiency, the speakers can maybe discuss them. The first was whether COVID has changed the prevalence or incidence of other infections, TB, pneumonia, and so on. And the second is what role tobacco and smoking actually have in causing COVID, and related to that, whether COVID could be seen as a very fast form of interstitial lung disease. And then there's some questions around COVID treatment, but maybe let's take those questions first, which really relate to global epidemiology, prevalence, and causes. So, Guy, maybe do you want to go on the change in COVID infections, particularly maybe in relation to TB?
Yeah, I think the net effect of COVID on TB is probably been adverse, and that there is evidence in 2020, in fact, and I don't think we know yet for 2021, of an increase in mortality due to tuberculosis, which is the first time that that's happened in 20 years. So there has been overall a net adverse effect, and that's probably because patients were not attending for diagnosis or for treatment because of the need to stay away from healthcare facilities and so on. But of course, there's possibility, it was an interesting possibility that the actions that people were taking to prevent the transmission of COVID by staying at home and social distancing and wearing a mask and so on might actually also reduce the transmission of TB and therefore reduce incidence of TB based on what I was describing before. But that effect, that beneficial effect, probably has been outweighed by the negative effect that I spoke about before. So that's in relation to TB. We did see, and I think Mark showed, was it Mark? Somebody showed the data on the dramatic reduction in viral respiratory infections during winter in many countries during the first year of COVID. Again, that was presumably due to the actions taken to prevent transmission of COVID, had beneficial effects on other viral respiratory diseases. So there's sort of been, from that point of view, a mixed impact.
Mark, did you want to add?
Yeah, I definitely think that there's, looking at the confinement that we had, there was a reduction, but once we're opening up again, we're seeing co-infection of COVID with other respiratory diseases or other bacterial diseases. So we need to be more aware and probably use the new PCRs to detect the new viruses and not only think that everything is COVID. So I think that's one of the things. I agree with Guy that definitely the patients with tuberculosis didn't get a diagnosis early and weren't treated, despite having a lower transmission with others because of the confinement. But definitely there was a lack of early diagnosis, and we see that with lung cancer, we see that with COPD, we see that with asthma too, not only infections. They haven't received the attention because they have been confined, and when they finally are getting back to having some medical attention, they are coming very late and with a lot of complications. And lastly, what you were talking about, the interstitial lung disease due to COVID, I think the majority of studies are showing that really it's around a 6% average of patients with with COVID that end up having pulmonary fibrosis. The majority of those will go ahead and not receive much treatment and will resolve, and some will have some restrictions. But the majority of post-COVID lung disorder, really, we thought it was going to be high for ILDs, and looking at the evolution, it has showed that it isn't as high. I don't know if Carlos wants to add to that. Mm-hmm.
Yes, if I may. I fully agree with you both, Guy and Mark, on all your remarks. I think we had less other infections because we had much more protection, of course, with masks and other measures. We had much less patients coming to our hospitals, so maybe that's another reason for tuberculosis and for the more severe tuberculosis scenario, because the patients came on a very late phase. So this is one. And I think it is true that after opening, we had much more viral infections. We had, for instance, flu out of season. We could see that last year, that we had this year, we had flu when in a period, for instance, here in Europe, in March, April, or more, even in summer, we are having still flu in some patients, and other viral infections in children. That was not the normal situation in this period. Regarding ILD, this is it, Mark. At the beginning, we were really afraid of having a huge increase of patients with ILD, because most of our patients that had pneumonia, some that went in the ICUs, they had organizing pneumonia with a trend to become a pulmonary fibrosis situation. And it was not really the case, because the majority of these patients having organizing pneumonia responded very well to the steroids. It is not, we cannot anticipate, because I think I saw in the chat there was a question related with this. We cannot anticipate if the early use of steroids could avoid this evolution. It is because dexamethasone was used since the beginning, when we had the serious infection and the patients receiving oxygen in our hospitals. But what is true is that it is much less than 10% of our patients have now an evolution to pulmonary fibrosis, and it was not what we previously thought.
Just that last question about the contribution of smoking and tobacco to COVID, or to perhaps to severity of disease.
Well, smoking and tobacco is awful for everything. It's not an exception, and we cannot say any other comment on that. But of course, we had main risk factors for COVID. The main risk factors were age, of course, obesity, as you all know, and many other respiratory and cardiovascular and chronic conditions, and of course immunosuppression, even coming from a disease or from therapy. But it is true that, of course, in heavy smokers, we had more severe situation when the disease was severe. We had a more severe and more difficult recovery from patients having severe tobacco habits.
Just one thing to add. One of the good things about the pandemic, there was a good percentage of patients that stopped smoking because of the fear of having worse outcomes because of the smoking. So that would be one of the positive things that we can get out from the pandemic, that there was a reduction in smokers during the pandemic. Hopefully they won't pick up.
Yes, and if I may, there are many other positive things that came from this, I would say, opportunity. It is not the case to call it opportunity, but vaccination was another one. I think people are much more aware now. The population, the general population, is much more aware of the need of this primary prevention through vaccination, that than before. And it was really good to see what happened worldwide. And I think it was also for us working on respiratory infections, something that we have still to promote and to take the advantages of this good position.
Perhaps if I can come in with a question, we've been talking about COVID, and obviously COVID has had huge visibility and interest across the world as a respiratory disease. A question's been asked that COPD is the third leading cause of death, yet it doesn't really seem to gain the attention that you would think amongst the general population or the media. Perhaps, David, can I ask you, do you have any suggestions why that would be?
I think it's difficult to talk about that globally. I can talk from a UK perspective that 20 or 30 years ago, COPD was very much seen as a self-inflicted smoker's disease that predominantly affected working class men who'd been in heavy industry. Most of those statements are untrue, but that was the public perception. And through sustained activities with the BTS, we've gradually changed that perception. So I now have relatively young women coming to my clinic, almost certainly with asthma, saying, I'm worried that I've got COPD. So I think it's a slow process of public education. People have argued about the name. I think we have the name we're stuck with, COPD. And AIDS or COVID are both abbreviations that people have readily got used to. So I think we should stick with COPD. We need to promote the fact, and one of the themes of World Lung Day is that respiratory symptoms are not normal. A lot of smokers who get old and get breathless and cough think that that's just normal for them. And I think we have to get across a public health message that respiratory symptoms of any sort, whether it's breathlessness or cough or inability to do things, are abnormal and need investigating. And I think then people will begin to understand the diseases that can lead to those. But it's a slow process. It's not something we can change overnight.
Thank you, David. And there was also a question about lung cancer prevalence, where amongst countries where we've seen a decrease in smoking prevalence, do we also see a decrease in lung cancer prevalence? David Lamb, sorry, I didn't specify which David earlier. Perhaps you want to comment on that one?
We are seeing some drop in the prevalence in lung cancer, especially in men who are smokers in some of the Western countries. But in this part of the world, in my part of the world, in Asia, lung cancer, both in men and women, are still stand at high prevalence, and also there is an increasing prominence of female non-smokers among lung cancer in our population. So we may be seeing a delay of the drop in the prevalence of smoking-related lung cancer after that drop, apparent drop of smoking prevalence in the Western world, but we are not seeing it in the Asian countries yet.
Thank you.
Can I make a short comment on this cancer? Because it was really this week on the last Tuesday that European Commission launched a new council recommendation. So a recommendation coming from the council on cancer screening that for the first time included lung and prostate cancer on our screening program here in Europe. So I think this is a very important step forward. It is still a little bit shy, and I, as the president of DRS and also the president of ELF, we react because of this shy step, but it's a step, and I think it's the first time that lung cancer is included in the cancer screening in Europe. I think it's a big step forward.
Thank you. That actually fits very well with the other area of questions, which is around diagnosis and particularly diagnostic strategies in low middle income countries. So we have a comment that, spirometry is important for diagnosis of asthma and COPD, but we need other diagnostic strategies for COVID, for example, and for the other diseases. And I would add to that even spirometry is largely unavailable in many low middle income country settings. So can I ask our panel perhaps to comment on what diagnostic strategies we think need to be urgently upscaled, particularly in low middle income countries, in order to more accurately define the burden. Because we've shown how some of the burden is actually unmeasured. I think, Mark, you had some slides on that.
So one of the things that GOLD is very interested in, I mean, spirometry remains the gold standard, but I think there are new technologies that can be used via smartphones that could at least be used as a screening measure. So I think adopting things like that is one way, new technologies, new approaches that we can overcome some of the airway disease diagnosis.
If I can comment, Heather, I think spirometry is obviously important to access, but I think the biggest hurdle is with regards to affordability, I think, in many low middle income countries. So I think probably one of the first steps is that patients should have access to the tools to make the diagnosis. It's largely unavailable because if it's going to cost someone a month's wage to have the spirometry test, it's not going to be affordable or available for testing. I think firstly we have to advocate for, as the hypertensive group, the diabetic group have done, that the first tool to make a diagnosis should be available and it should be free for service for patients. I think just getting people to be trained to use these tools is great, but patients should be able to access them and they should be available, and I think freely available if they're going to be used as diagnostic tools. I think we haven't advocated for that quite strongly enough in order to get people to have access to diagnostics for lung disease. I think before we even talk about CT scans, even peak flow meters are hardly used in primary care. And I think we need to start with the easiest tools to use and also ensure that they're available for people to use as well.
To add, go ahead, Guy.
You go, Mark. You go, and I'll come after you.
Living in a low middle income country in Guatemala, I think I agree with what Reflu probably lives the same issues that we have in Africa and Guatemala. Definitely awareness of the disease is our first step so that people will try to find and make their diagnosis, not only the healthcare workers, but the population. And then secondly, we do have questionnaires that kind of guide us to who definitely should try to get this spirometer done versus those that probably have a lower possibility, and because of the access and affordability problems, I think we can use those questionnaires to try to really get those that have positive scores to go and get a spirometry done. So I think that would be the way that we can try to get better diagnosis in the low and middle income countries.
I think in relation to asthma, we need to acknowledge that requiring spirometry as a prelude to getting treatment represents a major barrier to access. And that's actually not just in low and middle income countries. That would be the case in high income countries as well. That the vast majority of people who have asthma get treatment for the disease without having spirometry. And that is not, although that may feel unacceptable to purists, in fact, in terms of public health, it's probably the right outcome. And we need perhaps to test better how we can use symptom-based diagnosis or other diagnostic tools that are more readily available for identifying who will and who will not benefit from treatment for asthma. But as I said during my talk, there are regimens of treatment which save lives if you take them for asthma, and that's got to be the critical thing. And we've got to try and remove as many of the barriers to access to that treatment as possible. And one of them would be requiring spirometry before you can get access to effective treatment.
Guy, related to diagnostics, I know we're over time, so but just a quick question. I mean, it's from your talk, I got that you're suggesting active surveillance for TB in high burden communities. That would require a lot of upscaling of rapid diagnostics at point of
Yeah.
care?
Well, not necessarily at point of care, but at point of screening. And that screening could be is usually in a sort of village or suburb or locality where people are living. And yes, that is the case. The problem is that the tools that we've used up to now for screening prove to be not good. 50% of people in prevalence surveys who have TB do not report symptoms. So if you only test people who have symptoms of TB, you will miss 50% of the cases. 50%, the sensitivity of sputum smear microscopy for which is the conventional tool for the diagnosis of TB, is also about 50%. So if you use sputum smear microscopy for screening for TB, you'll also miss 50% of the cases. So neither symptoms nor sputum smear microscopy are really of any use as a screening tool. The only things that are of use are radiology or molecular testing of sputum. And both of those have been very substantial developments recently, which make them more accessible. In terms of radiology, there are ultra-portable devices that you can carry in a backpack, and there's artificial intelligence, AI reading. You don't actually need a radiologist, and both of those things make mass and cheap radiology screening now much more feasible. And the molecular screening is also rapid and automated and can be done with very low technology. Still a little bit expensive, but I think the cost will come down. So I think there are tools that make this feasible. And you've got to remember that in many countries, like my own country, this was already done, 50 years ago with much more primitive tools using radiology, basically, mass miniature chest radiology. And that's how TB was eliminated in countries like Australia and in many other countries. So it's what we need to expand to the rest of the world. Sorry, I've obviously said something that's made everyone go quiet.
No. That's good.
No, I think we're just over time, so I'm wondering whether we can go on for a bit or whether we need to stop now. Someone needs to. Sarah, what do you?
I think much as it would be wonderful to spend another hour discussing together, I think we should wrap up for the in the interests of time. And perhaps if I can just quickly speak for a couple of minutes and then hand back to you, Heather. So, I mean, I've really enjoyed listening to all of our speakers today. So thank you so much. And it's clear to me that, there's a huge burden of respiratory disease globally. And we also have a huge breadth of expertise and experience across the different professional societies that make up FIRS and many other groups that work on respiratory diseases worldwide. So I think this has really given us some food for thought ahead of World Lung Day. And David Halpin mentioned earlier GARD, which is the Global Alliance Against Chronic Respiratory Diseases, which I lead from the WHO side. So this is a network that's convened by WHO and comprises of many different respiratory organizations who are interested in reducing the global burden of respiratory diseases. So I think having listened to the excellent presentations today and reaching out to anyone who's listening now or comes and listens to the recording of this, I would just encourage you to link in and look forward to working together as we move forwards to try and reduce the burden of respiratory diseases worldwide and improve quality of life for people who are living with chronic respiratory diseases or acute respiratory diseases, because this is really should be the focus of our work. So I'll stop there in the interests of time and hand back to you, Heather, just to wrap up. Thank you so much, everybody.
Thank you. I echo Sarah's words. Thank you so much to our speakers and to participants. I think it's been a really wonderful webinar today, highlighting what we know is a very, very important and key area, but that is under-recognized when considering other non-communicable diseases. And I think as we work towards the Sustainable Development Goals of 2030, we really need to get on the global agenda access, affordability, to effective preventive and treatment strategies and diagnostic strategies, as was also highlighted today. And I think, you know, all of this that we've heard is really, really important to understand and perhaps to take forward, hopefully in a World Health Assembly resolution sometime, to get chronic respiratory diseases on the global agenda. It's been an absolute pleasure, I think, on behalf of FIRS to host this webinar, and big thank you to Sarah Rylance from the World Health Organization co-sponsoring this. I think working together, we really can make strides to improve equity and health for all. Thank you so much, and a good World Health Day to everyone all over the world. Thank you.
Thank you. Thank you, and goodbye.
Bye. Bye.
Bye,
Bye.
Thank you all.
Bye, everybody.
Have a good
Good, safe
take care.
air.
Right.